Good afternoon. I would like to thank Dr. Ghazali and the organizer of this meeting for inviting me to this very important meeting. Also thanks the chairmen and chairs for the committee's meeting. I would like to share with you some thought about my practice and by talking about the controversial aspects in adjuvant treatments of endometrial cancer. As a little introduction, while endometrial cancer is the most common gynecologic malignancy in the U.S., we are all aware that cervical cancer is by far the #1 gynecologic cancer in Egypt and many Middle Eastern countries. And I will focus more about cervical cancer tomorrow in our workshop. So endometrial cancer in general is mainly in the postmenopausal white women and mainly present in earlier stages. So stage 1 and 2 is basically about 85 to 90% of patients. Most of the time we see epithelial histology that constitute almost 95%, and sometimes we see mixed carcinoma or sarcoma, less than 5%. And even within epithelial carcinoma, we see the endometrioid type as well as serous and clear cell carcinoma. They are talking about type 1 endometrial cancer, which is mainly endometrioid type, and type 2, which is mainly clear cell and serous carcinoma. Just an introduction as well, the order staging system, FIGO 1988, has been in place since 1988 and only changed or revised in 2009. So the revision for the staging system is very, very important to us because most of the literature are using the current staging system, the 2019-9. As you can see, they modified the staging system by getting rid of stage 1C and including 1C in 1B. They are getting rid of stage 3A based on cytology, positive cytology, and also getting rid of stage 2A, which is endometrial endothelial involvement. So the management for endometrial cancer is mainly surgical, and this surgical staging system is well known to us. And typically after surgical staging, surgery by itself is curative in almost 80% of patients. However, some patients with high-risk features require some form of adjuvant therapy to kind of make their cancer-free interval is as high as possible. So sometimes we do radiation after hysterectomy or surgical staging, and we do typical external beam radiation treatment to the pelvic or the para-aortic or both together. Sometimes do brachytherapy to the vaginal vault. Sometimes we incorporate chemotherapy into this equation. We base this adjuvant therapy on many prognostic factors, and as we can see, stage is the most important prognostic factor. However, there is many other prognostic factors that we have to consider when we are deciding about the adjuvant therapy for these patients. We look at the depth of myometrial involvement. We look at the grade, what I mean by FIGO grading system. We look also at the non-endometrioid histology, as mentioned earlier, serous carcinoma and clear cell carcinoma. We also look at the lymphovascular space involvement and older age and other risk factors as well. So when we talk about adjuvant therapy in general, we are data-driven specialty, meaning we have to kind of justify our recommendation based on data. When I see data, we have to look at randomized evidence first if it's available. If it's not available, we have to go next level of evidence. So I just want to review with you the level of evidence quickly, because when we are recommending any adjuvant therapy, we have to justify it, as I mentioned, with evidence. So if there is level 1 or 2, which is basically randomized studies, that's fine. If there is no level 1 and 2, then we can go to level 3 and 4 and so on. And even when you read a randomized study, we have to look at the study very well. You look at the study design, you look at the analysis, you look at statistics. And very, very important, know that the statistics can be interpreted different ways. So I get this quote from Mark Twain, said like there is 3 kinds of lies, damn lies, and statistics. So the first case I want to discuss with you is a patient of mine who is 70 years old, African-American female, who underwent total abdominal hysterectomy, bilateral salpingo ovarectomy, pelvic and para-aortic lymphadenectomy, and peritoneal cytology for 1988 stage 1B, grade 2, endometrioid carcinoma, The tumor invaded 9 millimeter of 23 millimeter of the myometrium thickness. All 45 lymph nodes were negative of metastatic disease. There was positive lymphovascular space involvement, and peritoneal cytology was negative. So the patient had complete surgical staging. Then the question now is, for this particular patient, what you would do after surgery? Is observation is a good option? Is giving the patient pelvic external beam alone is a good option? How about vaginal cuff alone? How about combination of pelvic radiation and vaginal cuff together? How about chemotherapy alone? How about chemotherapy and radiations? All these options are making the decision sometimes difficult. So as a multidisciplinary team, we have to look at all factors and then come up with data or treatment that's justified by data. So to kind of come up with a recommendation for this particular patients, I'm going to quickly review some data to see what option might be justified based on data. So this will give me the chance to go over some of the major studies in stage 1 and 2 endometrial carcinoma. And I list the 4 major studies: PORTIC 1 2 study, GOG 99, and ASTIC and PORTIC 2, and the Swedish study that was reported a few years ago, or actually this year. How about the PORTIC study? This PORTIC study is a prospective randomized study for more than 700 patients, stage 1 endometrial carcinoma. All the patients had hysterectomy and salpingo-oophorectomy. Lymph node sampling was not required, cytology was optional, and the patient were randomized to whole pelvic radiation treatment versus observation. The study included patients like our patient, stage 1B, grade 2, up to grade 3, stage 1C, grade 1 to 3. They also included clear cell carcinoma and serous carcinoma. The primary endpoint of the study was local regional recurrence and overall survival. Again, this patient we're presenting is included in this study. And the median follow-up was very reasonable. However, more than 1/3 of the patients were low-risk patients. And within the study, they came up with risk grouping, showing that older age, deep myometrial invasion, and grade 3 were associated with negative prognostic factors. And again, without doubt, adding radiation treatment post-operatively after hysterectomy for this patient improved local regional recurrence. And the recurrence rate went from 14% for those who had no radiation post-operatively to only 4% after adjuvant radiation treatment. There was no significant difference in overall survival between these two groups, but this is a different issue because most of these patients are older with many comorbidity, and most likely they die from other issues rather than cancer-related issues. I'm just going to skip this one for the sake of the time. And again, for the conclusion from this study showing that adding radiation post-operatively in patients with stage 1 and 2 significantly reduce local recurrence by adding radiation to the whole pelvic. The second important study as well is gynecologic oncology study 99 that was reported in 2004. Similar study design, again, included one of our similar patient grouping, so stage 1B, similar to our patients. And they had about 400 patients. And in this particular study, what is different compared to the PORTIC study is they required and mandated surgical staging. So lymphadenectomy was required, peritoneal cytology was also required. And the study design was similar, pelvic radiation versus observation. Again, no central pathology review was required in this study, and the study primary endpoint was recurrence-free survival. Again, they confirmed similar prognostic factor, mainly older age, the presence of lymphovascular space involvement, as well as the depth of invasion as bad prognostic factors. Similar number, 2 years recurrence-free survival was about 12% versus 3% with the addition of radiation treatment. Pelvic recurrence was also reduced, and 2-year overall survival was not different. So just for your own knowledge, when you look at the paper, there was 18 recurrences in the observation arm and 3 recurrences in the radiation treatment arm. But if you read carefully the author's disclaimer, these 3 recurrences, in fact, 2 of them did not receive adequate radiation, did not receive radiation alone. But because of the analysis was based on intent to treat analysis, they were basically censored as radiation patients. So in reality, active treatment, 18 recurrences in the observation arm versus 1 recurrence in the radiation treatment arm. And again, similar curves showing that adding radiation postoperatively after hysterectomy significantly reduced local recurrence after surgical staging. I'm just going to quick fast because of time. The third important study is ASTIC study and NCI Canada study. Again, it's pooled analysis results of almost 1,000 patients with stage 1A and 1B grade 3, 1C, and 2A all grades. Again, this study did not include our patients, did not include 1B grade 2. And again, randomized patient to same radiation treatment versus observation. In this study, the high-risk histologies was also included. They included serous carcinoma as well as clear cell carcinoma. Patients with positive pelvic lymph node were eligible for this ASTIC study, not the NCI Canada, but the ASTIC study. Vaginal brachytherapy was also allowed and was optional. Cytology could be negative, could be positive in this study, and because it's pooled analysis, the randomization methodology was different between ASTIC and NCI Canada. This study was designed to enroll more patients, more high-risk patients. As I mentioned, it did not enroll our patient, which is 1B grade 2. That you can claim that they consider 1B grade 2 as low-risk patient, and that's why adjuvant radiation is not even recommended, and observation might be a good option for this patient. 8% of these patients in the study group ended up not receiving assigned treatment, and 2% of the patients in the observation arm ended up receiving adjuvant radiation treatment. And median follow-up was very, very reasonable. Again, if you can see the curve here, adding radiation post-op definitely reduce local failure, but not for all patients in the study. Toxicity also scored after completion of external beam radiation treatment and roughly after 4 months of surgery. Patients received adjuvant radiation treatment, reported significant more side effects compared, of course, to observation. And the conclusion from the author in this study showing that adjuvant radiation treatment does not improve overall survival. The absolute benefit of external beam is preventing local recurrence is small and not without toxicity. So we have 3 major studies clearly showing that adding radiation post-op reduced local recurrence, and then with some side effects. But the question now is, since some studies reported some toxicity from pelvic radiation treatment, the question arises, can we use external beam or vaginal cuff is adequate, or we need to use both of them? So an important study came, which is PORTIC-2 study, and another Swedish study came trying to answer this question for us. And again, for PORTIC study, which is very important study, looked at similar grouping, stage 1 and 2A disease. So they included our patient that we proposed. Patient randomized to either pelvic radiation treatment alone to same dose, 45 or 460 gray, and vaginal cuff brachytherapy using high dose rate or lower dose rate. And cytology was required, but routine lymphadenectomy is not required. Clear or serous carcinoma were excluded from this study. Central pathology was done. So the study was very well executed overall. And they also had a very nice component of quality of life. So they looked at the patient quality of life before treatment and after treatment as well. Again, the primary endpoint for this study was vaginal cuff recurrence. They did not look at local regional recurrence. So their main goal is vaginal cuff recurrence. As you can see, between the 2 arms, vaginal cuff recurrence was similar, but pelvic recurrence was slightly higher in the vaginal cuff brachytherapy group. Based on the quality of life component of the study, they concluded that vaginal brachytherapy is effective in ensuring vaginal control with fewer gastrointestinal toxic effect than external beam radiation treatment, and should be the standard of care for patients with endometrial cancer of high-risk intermediate group. So this study justified the use of brachytherapy alone to our patients. the previous 3 studies justify external beam alone for these outpatients. And then the important Swedish study that was published early this year, looking at brachytherapy alone versus brachytherapy and external beam together to see whether the addition of external beam, in fact, adds benefit to the patients or not. So they looked at almost 530 patients with endometrial carcinoma. They did not include 1B grade 2 like our patients. They limited the study to those with high grade and deep myometrial invasion. They also allowed patients to be enrolled in the study if they have DNA, aneuploidy, or nuclear grade 1 and 2. Negative cytology and lymphadenectomy were optional. And after the hysterectomy, patients were randomized to adjuvant vaginal cuff radiation treatment alone, with or without pelvic radiation treatment. And the primary endpoint of the study was leukoregional recurrence and overall survival. And they allowed different brachytherapy doses between high dose rate and low dose rate. And the median follow-up, again, was very, very reasonably. And when you look at the 5-year local regional relapse between the 2 groups, vaginal cuff brachytherapy relapse was 5%, and the addition of pelvic radiation treatment and vaginal cuff rate is 1.5. However, the p-value was significant in favor of pelvic external beam addition to vaginal brachytherapy. When you look at the overall survival, there was no difference between the 2 groups. When you look at disease-specific survival, again, there was no difference between the 2 groups. How about chemotherapy? So we talked about radiation, external beam, vaginal cuff, or combination of 2. How about chemotherapy? Do we have data justifying using chemotherapy alone for patients with 1B, grade 2, older patients with angiolymphatic infiltration? Let's look at what we have for data. So the RTG study 9708 that was published in 2004 was a phase 2 study, looked at only 46 patients with high-risk endometrial carcinoma stage 1 and 3. All patients underwent surgical staging. Patient grade 2 to 3 or 1C or 2B to 3C pelvic lymph node were included. All patients received adjuvant radiation treatment with 45 gray and vaginal cuff brachytherapy. With chemotherapy consisted of cisplatin and radiation was, after radiation, 4 cycles of chemo were delivered, consisted of cisplatin and Taxol. After 2-year, pelvic recurrence rate was 2%, similar to the pelvic recurrence from Portic and closer to the pelvic recurrence after GOG and Portic 1. So the author concluded that chemotherapy and radiation in patients with high-risk feature might be feasible and worth considering for some patients. The currently open study, GOG 0249, is an ongoing study. The major question for this study is, since some patients with endometrial cancer fail outside of the pelvis, can we reduce distant mets and also try to reduce micrometastasis within the pelvic? So they are enrolling patients with high-risk features, stage 1 and 2, with grade 2 and 3. This is similar to our patient, grade 2, positive lymphatic infiltration, like our patients, and deep myometrial invasion. They allowed clear cytology and serous cytology to be also included. And the patient were randomized to pelvic radiation treatment alone, and they allowed allowed brachytherapy as an option, but the other arm was mainly chemotherapy and vaginal cuff alone. And the study is ongoing, and we hope to see the results of this study within the next year or so. So back to our question. We have almost 5 options or 6 options. The observation alone can be justified based on ASTICS trial and Swedish study. Pelvic external beam alone can be justified on GOG 99 and Portic 1 to study. Vaginal cuff brachytherapy also can be justified based on Portic 2 study. The combination, there is no data to support the combination of pelvic external beam and vaginal cuff for this particular patient. Chemotherapy alone, as of yet, there is no to justify chemotherapy alone. Chemotherapy and radiation, the RTOG study and the currently ongoing GOG study might give us some clue about our direction. In my own practice, I favor doing a vaginal cuff brachytherapy for this patient. So the purpose of this case presentation is to let you know that there is many options available for our endometrial cancer patients after hysterectomy. We got to use the data to justify why or why not we are using these adjuvant treatments. Also, we have to consider quality of life for these patients. So if one treatment is very effective but comes with a lot of side effects, you may skip this option and go to the less toxic option with no much difference in local control. I'm going to switch gears a little bit to present a case of advanced endometrial cancer, because it's still a controversial issue, how we best manage these patients. So I'm presenting one of my patients again, who's 66 years old, white female, who undergoes hysterectomy, surgical staging completely, cytology, everything you can imagine. And pathology reveals uterine endometrioid carcinoma. This time is grade 3, with involvement of cervical stroma, deep myometrial invasion. The right ovary was involved, and the cytology was positive. No lymphovascular invasion was detected, and one lymph node in the para-aortic area was involved with disease out of 32 lymph nodes removed. So, per the staging system, she was staged as stage 3C2. Then how you manage this patient after surgery? We have option to do chemotherapy alone. We have option to do radiation treatment alone to the pelvic and the para-aortic area. Or we have option to do the chemotherapy and the radiation together. And if you select this option, how you sequence the radiation and the chemotherapy? Are you going to do chemotherapy first, or radiation first, or the other way around? Or you can do sandwich technique, like chemo first, radiation, and then more chemo down the road. Or you can do radiation with concurrent cisplatin chemotherapy from A to Z. So let's go through the data to see what option the data support. So the data I'm presenting is the Gynecologic Oncology Group study 122 and 184, and the currently open study 0258. The study was reported by Dr. Randall about a few years ago. It's a study for stage 3 patients with endometrial cancer who had hysterectomy and full surgical staging with a residual disease less than 2 centimeters. The patient was randomized to whole abdominal radiation treatments to 30 gray, followed by a 15 gray boost, or chemotherapy alone. But the chemotherapy was different from the currently used these days. They use adriamycin and cisplatin for 7 cycles, and then give the 8th cycle with cisplatin alone. So it's basically chemotherapy alone versus radiation treatment alone. Because the study was trying to answer an important question, the mandated central pathology review, and the study primary endpoint was progression-free survival. The second study endpoint was overall survival. When we look at study, again, it's important to look at the inclusion-exclusion criteria and how they analyze the data. So the randomization process did not include a stratification one, meaning they allowed all the patients with stage 3 to be enrolled. So for any lymph node number, any lymph node status. Only 50% of the patients with endometrioid histology, and the rest was serous and clear carcinoma. Median follow-up was very reasonable. 63% completed the assigned chemotherapy treatments. Not all the patients got the full chemotherapy course. 84% of the patients assigned to the whole abdomen completed the radiation treatment course. And when you look at the initial failure, the pelvic failure was more with chemotherapy arm, and the distant failure was more with the radiation treatment arm. And when they report the study, their initial presentation at ASCO showed no difference in outcome between the radiation or the chemotherapy. However, when the manuscript came, they did some adjustment for the stage simply because the radiation treatment arm had more patients with lower stages and lower number of prognostic factors. So they did some statistical analysis to readjust and weight the entrance and the number for patients to make it what's called stage adjusted. And when they did that, they reported that chemotherapy by itself is better than whole abdomen radiation treatment. A technique, by the way, who are no longer used these days. At 5 years, overall survival is 55% for the chemotherapy group versus 42% for those who had whole abdomen radiation treatments. So based on this study, chemotherapy alone can be justified for any patient with stage 3 or 4. The other study that was published after that was a study for GOG as well. We enrolled about 560 patients with stage 3 and 4, less than 2 centimeter residual tumor, randomized to radiation treatment to 50.4, and brachytherapy is allowed in these patients. And after completion of radiation treatments, patients were randomized to chemotherapy with adriamycin cisplatin versus chemotherapy with adriamycin cisplatin and paclitaxel. So this is radiation first, followed by some sort of chemo, whether cisplatin and adriamycin or cisplatin, adriamycin, and paclitaxel. And they reported that the addition of paclitaxel did not improve outcome, but in fact increased toxicity significantly. The ongoing study is looking at the sequence question or the combination question between radiation and chemotherapy together. And we are one of the major accrual of this study at Henry Ford Hospital. So this study is basically randomizing patients with stage 3 and 4 to pelvic radiation treatment with concurrent cisplatin, followed by more for chemotherapy down the road, compared to chemotherapy alone. So when you read the introduction of this study, they can justify radiation with chemotherapy as an option versus the standard of care as another option. So if you look back to our patients, she can be assigned to...
Excuse me, Dr. Mohammed. Please, we are limited with a certain time, so please go quickly.
Okay.
Thank you.
Sure.
Sorry for interruption.
I have only a few questions. So now the question is chemotherapy alone or radiation alone or a combination. And the growing data support the combination of the two together so we can address the local component as well as systemic component. The question of sandwich technique, is it a good technique to use? I think it's a good technique to use, but it's very, very important to consider when you are doing sandwich technique, you have to kind of stage the patient after the chemotherapy. I'm going to quickly go over some patient who had chemotherapy and then coming to us to get radiation treatment. And when you do simulation with IV contrast and oral contrast, we see that they are progressing during chemo. So it's very important to do staging after chemotherapy. Do not assume it's adjuvant because it might be salvage session. So this patient was getting chemo and then developed para-aortic lymphadenopathy, as you can see in the arrow. Similar, different patients. I'm just going to go quickly. Again, more progression during chemo and coming to us for adjuvant radiation treatments. So again, for this particular patient, you can justify chemotherapy alone. You can justify chemotherapy and radiation based on the current study and the published GOG study. But the question now is the sequence, how you sequence this treatment option best. So in conclusion, surgical staging is a cornerstone of curative management of uterine carcinoma. The role of adjuvant therapy must be customized to each patient. And you have to kind of validate your recommendation based on randomized studies at least. Adjuvant treatment need to be customized to each patient. The role of multimodality therapy, which is chemo and radiation, is very promising. Thanks for your attention.
Thank you very much, Professor Dr. Mohammed.